manipulations this area, and this if that is an unstable joint, that could produce a lot of problems, right? So that is the plantar-axial joint here. Going on, you see, usually the cervical vertebrae has got a lordotic curvature in its anterior side. Okay, curvature on its like this. It should be like this. Okay, you can see a straightening of the lordotic curvature here. That can be assessed by 3-4 lines. Not that important for us, but still, if there is spondylolisthesis, that is slipping of vertebrae over the another, that can be assessed by looking into this one. This is the anterior vertebral line. This is the posterior vertebral line. This is the interspinous line, and this is the posterior spinous line. Not that important, right? So, to see whether there is any stepping, if this vertebrae flips over like that, there will be a small stepping like this. Okay, so that aspect should look like that. So this is what I told you, that there is two spaces here called as retropharyngeal space and retrotracheal space. So this space roughly should be assessing that this space should be 1/3 of the corresponding vertebrae, right? Up to C4, it should be like this. Corresponding vertebrae is this one, so it should not be greater than 1/3 of the size of the vertebrae. This space, 1/3, 1/3. And this should be roughly the size, should not go more than the space of the corresponding vertebrae, the protracheal space. That is below C4, C5, C6, it should be on the same size of the vertebrae, and this one should be 1/3, roughly. What happens is that this space can increase if there is pus collection here. Usually we do not come across with such cases, but still, if there is a pyogenic infection, then pyogenic arthritis, PV spine, etc., there can be a collection of pus over here, leading to increase in space in this area. I will show you an X-ray, but usually we do not come across such cases. Okay. So laterally you have a limitation that usually you cannot see the C7 T1 joint. So modified use are taken like Sumo's view, etc. We do not go through to look like complicated like this. Usually we don't take that Sumo view. Okay, so we can skip through that. This one is called as a peg view. In the initial slide, I explained that cervical vertebrae should be taken in as two different anatomical structures. That is, the C1 and C2 should be taken as together, and C3 to C7 should be considered as a separate entity. Because in an AP view, we saw that you can actually visualize C7, C6, C4, C5. Sorry, C5, C4, and C3. But C1 and C2 are not seen. Right. So there should be there is a modified AP view that should be taken, and that is taken with the mouth open like this. Okay, you open the mouth and the X-ray beam is passed through the mouth, so that you get the because when we saw the AP view, we saw that the C1 and C2, that is the atlas and the axis, are obscured by the presence of the mandible, isn't it? We visualize only C3. Right. So C1 and C2, to visualize C1 and C2, that happens because sometimes what happens is that osteoarthritis can develop in the upper cervical vertebrae, C1, C2 joint, or the CO. CO means the occipital joint, C0, the Atlanto-occipital joint, and so on. So if you want to visualize that one, C1 and C2, then you should be taking a modified view called as peg view. Usually, peg view should not be written; it should be written as open mouth view. As the open mouth view or C1, C2 view. Right. So open mouth will be more or less the apt term to be used, but still it's called as a peg view because it is used to visualize the peg. Peg means the odontoid process. Right. The peg view can be used to visualize C1 and C2 joints. It will be looking like this. Okay, this is an open mouth view. So you can see the mandible with the teeth in the lower jaws here. You can see the teeth here, isn't it? And you can see the C2 vertebrae here. C2 vertebrae with the dents or the peg. Odontoid process, dents or the odontoid process. That can be seen here. And these are the two lateral muscles of the Achilles. And you can see a joint here. Right. This is called as the Axial joint. So not the Axial joint, the apophyseal joint between the C1 and the C2 on both sides. Here also you can see. Usually this should be, the dents or the odontoid should be coming in equal alignment, like we saw in spine, isn't it? This distance should be equal to this distance. Okay, this is the main assessment scene. This is taken when we have suboccipital pain. Okay. You will see that patients complain with suboccipital pain on the back side of their neck or on the axial part of their neck, or this part. And if you suspect that there is a osteoarthritis or a radiculopathy that is originating from the C1 C2 joint, then the view that should be suggested is the peg view or the odontoid view, or rather you can write it as the open mouth. Right. This one is the main thing. Right. You can take AP, you can take lateral, you can take odontoid process. But as a clinician, an Ayurvedic physician, the main view that you should be doing is that most people do not write this. But I think that most of the people should be more and more writing this view, but as the oblique. Okay. This is done in patients with pain or altered sensation of the upper leg. If you have a patient with radiculopathy, okay, neck pain with radiculopathy, right? Neck pain with radiculopathy as well as or with neck pain with weakness of the upper leg. Okay, dermatons and myotons, you know that terms, isn't it? So if a patient come with, say, weakness in flexion, weakness in abduction, or the patient come with radiculopathy, numbness, pins and needles over his upper arm. In such conditions, what happens is that we should be viewing the intervertebral foramen. You know that, isn't it? There is a foramen through which the nerves comes out. So that's the intervertebral foramen. It is produced by a pedicel on the upper part, pedicel on the lower part. There is a foramen on the lateral side through which the nerve roots comes out. And if there is a stenosis or a constriction of that particular foramen, then that can produce what is called as radiculopathy. And if you want to see whether this stenosis is producing the radiculopathy, then you should be writing what is called as an oblique view. AP and lateral views are not that important. Only the lateral view will give an idea about the apophyseal joint, which can be clinically analyzed. But one want to see that this should be, if a patient complains with neck pain and radiculopathy, definitely write what is called as oblique view. And again, oblique view are of two types, left and right. Right. If a patient comes with left side radiculopathy, you should be writing oblique left. And if a patient comes with radiculopathy on the right side, you should be writing. So this view is particularly written with an aspect to see the intervertebral foramen only, exclusively to see the intervertebral foramen only. You can see this. See, Sporo look like a lateral, but it's not what we saw in a lateral view, isn't it? Somewhat different. And you can see the foramens here. See, this is the intervertebral foramens. Right. Right. If you want to see this intervertebral foramens, you should be writing a oblique, right? Oblique right or an oblique left. Right. So the intention is to see whether this one is, again, here is some technical aspect related with oblique view we should be keeping in mind before assessing a oblique view. Oblique view can be taken as anterior oblique and posterior oblique. Never mind about that. See for the markers. R and L. Okay, so I'll skip through this part. So just to see what see the marker. This marker is kept on this left side. That means you are viewing the same side foramen. Just to keep that, I skipped the technical aspects because it is a lengthy process. So I just skip through that. We'll go to the pathologies. So see the marker. If the marker is put on the back side of the neck, that means it is on the same side. We are viewing the same side foramen. And if the marker is put here, then you are viewing the opposite foramen. So usually, if you write that oblique left, usually the technician will be giving this view. Just see that the marker is put on the back side. If that is correct, we are seeing the left side foramen. Yeah. Isn't it? Where the foramen is narrow. You can see. Isn't it? Narrow foramen. Right. Another view. Again, this is the right side. You can see the foramens here. 1, 2, 3. Yeah. Right. So, patients presenting with radiculopathy always write an oblique view. Clear. Here we can see this is an oblique view. You can see the foramens here. It's a normal foramen. There is another normal foramen. There is another normal foramen. You can see that. This foramen is narrow. Clear. So this is the C6 foramen. So this patient will be producing C6 radiculopathy. Another view. Right. So you should be seeing the this patient has this technician put the slide on the anterior side. That means this is the left one that is producing, but you are viewing the right foramen. That's what I said. This. Right. So oblique views are taken to view the intervertebral foramen. I'm repeating that because that is an important view. We'll see how. Another one. So, try to see some of the pathologies. Right. This is a lateral view taken. Should be looking into there is. I'll tell how I assess this X-ray. Okay, so that you can get an idea about how I approach things. Okay, you can see the first one, second, third, 4, 5, 6, 7. Right, the vertebral prominence is here. So first you will be seeing the apophyseal joints. See the apophyseal joints, whether they are normal. Okay, then coming down, you can see there is an osteophyte formation here. You know the osteophyte formation? Do I need to explain that? Osteophyte formation is the projection of the vertebrae, which can be either anterior osteophytes or posterior osteophytes. Anterior osteophytes are not of much of importance because these are just anatomical changes that is occurring in the vertebrae. But posterior osteophytes are of significance because these posterior osteophytes can impinge nerves. So you should be looking into this area that can be seen in oblique view. I will try to explain that in oblique view. Right. So there is reduced space over this joint. Right, C5, C6 joint, lateral view. But I would rather take an oblique view in this condition because this type of changes should be always producing radiculopathies to the concerned sites. So that should be taken. Right. Again, look into the apophyseal joints. See the apophyseal. Lateral views should be taken to view rather the apophyseal joints rather than the intervertebral disc space. That will be there, that everybody can appreciate, but you should be looking into the apophyseal joint. That is much important than the space. Okay, because most of the cases come like that. You can see the narrowing of sclerotic changes occurring in this part. In this part. Okay. Please ask queries so that I can give a better explanation. Because usually when I take classes, people do respond. Okay, this is the joint which I told about. This is the Atlanta axial joint. This part. Okay, that we will see. Okay, this is a special type of view. Can anybody tell there's a structure you can see here? See the structure here. Can anybody tell which the structure is? Anybody? I will give you 10 seconds. Can anybody tell what that structure is in the chat box? Or you can tell.
Yes, doctor. Someone is thyroid. Someone is answering. Murshida doctor is answering thyroid. Thyroid.
Stop thyroid. Stop thyroid. No. Stop thyroid. Dr. Murshida, it's not thyroid. Okay. Thyroid, the position is coming from the thyroid aspect. Okay. Thyroid comes here. Thyroid cartilage do come here. But this is the vertebral artery going through the transverse foramen. Right. You can see some calcified borders here also. This can be seen in some X-rays, especially in aged persons. You can see this, but there is it can produce atherosclerotic changes in this vertebral artery, which can produce some sort of, we'll discuss that later. Okay, this is vertebral artery going on here. So the smoke point. Artery, okay. Artery is normal. It's vertebral artery. Okay. This is another lateral view. You can see the apophyseal joints. Whenever you take an lateral view, first look into the apophyseal joint. Now just look into the disc space. Disc space, you can see the changes here. Of course, everybody will be appreciating that. But please see the apophyseal joint. Okay, you go through like this, and you can see the changes here. Can you see? Okay, there is a sclerotic changes and the irregular borders coming here. Right, here also you can see that. So we producing facet joint arthropathy. Okay. Right. There's another one. See here. See here. Yes. Here also. These three joints are involved, more or less. Again, also the space reduction and vertebral body reduction here also. Right. So that is how you interpret an X-ray lateral view. Here also you can see. Okay, this which view is this? Anybody can tell which view is this? Anybody? Okay, Kiran, just oblique view. You can see a finding here. See, this is a normal foramen, right? This foramen has a projection here, going inside into it, right? This is an osteophyte. Okay, this osteophyte is narrowing the individual foramen. And most likely, this patient will be having a C7 radiculopathy, right, because of this thing. And corresponding facet joint is also involved. You can see that. Okay, so this is how you look into the oblique view. Right. You can look into the foramens and see whether any facets are going in or is there a total narrowing of this foramen. Can anybody tell which this one is? Thank you. Right. Good. Thank you. You can see, compare this joint with this joint. Compare this joint with this joint. You can see the sclerotic changes with the osteoarthritic changes happening in this joint. Can you appreciate that? Okay. So this patient most likely will be having a suboccipital pain or suboccipital radiculopathy. Right. Unfortunately, there is no marker here, so we cannot tell which side that comes in. Okay, these are the, we'll see, we'll discuss that later. One other thing you will see is that what is Eagle syndrome. This is commonly seen in your clinical practice. Not commonly, but occasionally this thing will come. And it will see a structure like this. And anybody see a structure like this? What is this? Can anybody say what that could be? This is called a stylohyoid ligament, calcification of stylohyoid. This is a congenital deformity, congenital thing. That is, the stylohyoid ligament can get calcified on both sides, producing what is called as Eagle syndrome. This is called as Eagle syndrome. It's not because it is related with Eagle, because it was first identified a person called as Eagle. So it's called as a stylohyoid ligament calcification. Should be differentiated with vertebral artery calcification. We saw a projection, AP projection, where I told you that it's a vertebral artery, but at an IP view, Eagle stylohyoid ligament calcification can produce such shadows. So that should be differentiated. This can be, the patient may be presenting by sensation of something stuck in the pharynx. Something is holding here, and there is a difficulty in swallowing, shooting pain from throat to ear. All such things will be happening. Headache, tinnitus, all such presentation will be shown. And if you take an X-ray, you will be seeing this type of thing. Okay, if you see this thing, then unfortunately you should not go for further medicated treatment. This should be surgically correct. Right. So Eagle syndrome, if it's an incidental finding, you will not find that due to any particular clinical finding. But if you occasionally, when you take an X-ray, you can see such things. Many times that may be asymptomatic, then that can be left alone. But such things can occasionally come across. Right. So Eagle syndrome, keep in mind, if such a presentation is, you can just refer that, may not treat that condition. Other conditions, you can see the silent process here. See? Eagle syndrome. Right. In my clinical practice, I have seen 3 such cases. Two were asymptomatic. So local treatments were given. But one patient had severe problems. She was referred for surgical management. Right. So this thing can come across. You can come across. Another one here also you can see. Okay. So keep that in mind. Eagle syndrome. Okay, now I'll show you some unusual findings that can be seen on an X-ray. Unusual findings. Any abnormalities that can be detected. There's an arrow shown there. Anybody could tell what that is?
Cervical rest.
How? Cervical rib. How?
The T1 is noted in the X-ray, and above it is seen that.
How?
The T1 can be identified by the transverse process. So above that it is some.
Okay, very good. The transverse process here, you can see the transverse process going upwards, isn't it? This one is going downwards. This is the cervical rib on both sides. Actually, it is not a cervical rib. This is an enlarged transverse process. Cannot see a rib like this. Can you? No. It's an enlarged transverse process, more or less acting like a rib. Right, on both sides. With the direction of projection, that is how you identify cervical rib. The direction of projection of the cervical rib, you can see that this one is of cervical origin. C7 transverse process enlarged, acting like a cervical rib. Right. This one you can see, isn't it? This part. You can see the rib-like formation. Okay. This transverse process is pointing upwards. This one is pointing downwards. You can see the cervical rib again. Right. So that here you can see that actually there is no rib formation here, but the transverse process is a little bit enlarged. This side you can see the rib here. Right. Another one, bilateral ribs. Okay. This is not C1, this is cervical ribs on both sides. Because of the transverse process pointing downwards. The upward pointing ribs is here. Okay, this one is this rib one. Okay, this is the cervical rib. Again, this is osteoarthritis. I explained earlier, the osteophyte formation in the anterior side. Anterior side osteophyte formation is not much of a significance, but occasionally this could produce difficulty in swallowing. Right. Otherwise, it does not produce much of a symptomatic problems. The thing you should be looking is posterior osteophytes, which you can appreciate here. Actually, this is a lateral view, but you should be taking a oblique view to appreciate the sequence. Right. Again, same. If you see these vertebral shadows like this, always take a lantern to see whether it is a styloid ligament that is producing the shadow. There are also another one. If anybody could tell what the pathology here is? Anybody?
Loss of lordosis.
Sorry?
Loss of lordosis.
Loss of lordosis is there. Yes. Loss of lordosis is here. Yes. Then you have the facet joint problem here. That's okay. Any other abnormality? Specific abnormality seen in this X-ray. Anybody could explain that? So I already explained. Take a few seconds. Let's go through. I'll put my arrow here and then anybody could tell. Yes, right. You can see the styloid ligament coming out like this. Styloid process to the hyoid bone. Okay, Eagle syndrome. Okay, so look into this area. Okay, and see these things. In the open mouth view. Anybody can tell what this is? Take a few seconds. First, which view is this? Which view is this?
Oblique.
Oblique view. Oblique? Oblique left, isn't it? Are you viewing the same side or the opposite side for Anand?
Same side.
Same side for Anand. Because it is the marker is put on the back side. Right. Then, any other finding?
Cervical radical. Cervical radiculopathy.
Cervical?
Cervical radiculopathy. The foramen is.
Cervical radiculopathy is clinical. It's a clinical finding, isn't it? I'm specifically asking about the
Foramen narrowing.
Excellent. Which foramen narrowing?
C6, C7.
Isn't it? Isn't it? Or this one? No. This one or this one?
C6, C7.
Right. So corresponding C7 nerve root will be involved. Again, so these are the osteophytes. You can see oblique. When you look into the oblique, see whether there are posterior osteophytes. Here you can see an osteophyte. Here you can see an osteophyte. Here also you can see. This foramens are more or less. So this can impinge the nerve root coming out of there and produce radicalities. So this is what you should be basically looking into, right? This one. You can see the fused vertebrae, isn't it? This is seen in bamboo spine, ankylosing spondylitis. Not commonly seen in the cervical region. You can see it can be there, but usually you will find it in the lumbar region. Right. So another one. Any abnormalities here? Because you can see the appreciate is scoliosis, isn't it? Scoliosis. Scoliosis there. Any other finding?
Bifida.
Bifid spine. Right. Spina bifida. Can you see that? Actually, this is seen in the lumbar region, but occasionally it can be seen in the cervical region. It's a bifid spine. Not a bifid spine, spina bifida. Here also you can see that. Occasionally this can be seen. Right. This patient does have a cervical spine also. Sorry, cervical rib also. This can be also seen. What is this? Anybody?
Fused vertebrae.
Used a block vertebrae. Okay. So usually block vertebrae is associated. This is a congenital thing. This is usually related with congenital lung disease and also congenital kidney diseases. If you see such things, please see that whether the patient is having respiratory problems or nephrological problems. Okay. So that is one of the indicators. This is an occasional finding. But when you find that, you should be looking into the kidneys and the lungs also. Anything? Don't feel that I was teaching a cervical spine, cervical X-ray, and suddenly I have shown you a lung X-ray. But I gave you the indication earlier in the class, looking into a particular area, isn't it?
Right
The
upper
apex.
lung before
Yeah, you can
right.
fantos tumor. There you can see that. Okay, so it may be incidental finding. When you take the cervical AP, this area you can see, and you see the opacities. See clearly the opacity coming here. Right. This could be an incidental finding while you take a cervical X-ray. So just not look into the spine or the vertebrae only. You should be looking into the other one also. Right. This I have just skipped through. I have given a basic overview of how a cervical spine X-ray should be taken and what are the basic things you should be looking into. I didn't tell about any management aspects, but I will show you some of the medicines I use in the treatment. This I will tell. You can ask any doubts regarding the management. Then only I can tell whatever. Okay. Usually regarding cervical spine disorders, usually we in Kerala practice we usually use labas or PV. Right. So there are different types of labas that can be used, ranging from Kolagulatadi, Kottajuttadi, Gifadumadi. All these three, or rather four, these all are three things are Vata Kapha Shamana in nature. So usually, if a patient present with neck pain and stiffness, right, you can go for these three churnas as labas or ranging from the basic one is from Kolagulatadi, then Grihadumadi, and finally Kottajuttadi. Right. If the patient is having, say, Pitta Anubandhata, like if you touch the patient's particular red and if you raise in temperature, then you can assess that there is a Pitta Anubandha there. Then you can go for Nagaradi or Ellam Nishadili. Right. Kartavata is also used as a Pitta Shamananda. Asnadi, more or less neutral, but basically it is Vata Pitta Shamana. Okay, so you should not be using a Pitta Shamana drug in a Vata Kapha condition and vice versa. These three things should be used in Vata Kapha conditions, and this should be used in Vata Pitta Shamana conditions. Just skipping through it fastly, you can ask doubts whenever you see. Then Kulatagi is one another thing. Okay. And Thailas, I generally don't use Thailas in cervical region. I generally prefer Shiropianas, right? But still, you can use Karpuradi, Kottajuttadi, or Chinchadis. These are the three ideal Thailas which I use. Murvana is not a good choice. I think so. Because Murvana can produce Tampana and it will give pain relief. Okay, that is there. But regarding the progression of the disease, Murvana I don't think will be a good choice. This is what I use. Then Shiropiga is of prime importance. What happens is that the patient with cervical spondylosis or spondylopathy, right, or radiculopathy, you give medicine, and the patient will get symptomatic relief for a short, brief period of time. What happens is that the patient go through routine lifestyles and again come back with the same disorder, with again neck pain and going on like that. Right. So one thing we can advise is that you can give Shiropiana. You should prevent further progress of the disease. It's actually these two things, Stabilivadi and Carpocessa, very good results. The only thing is that you just advise them to just do the Shiropiana and also do a massage over the back part of the neck, like this, over the shoulder. The same time, either using Stabilivadi or Carpocessa. Carpocessa is an excellent drug. You can use that for Shiropiana. That will give long-lasting remission of the disease. Thumbs up rule, Carpocessa. Then Kedagi Muladi can be also used, but Kedagi Muladi and Rasadila. Both of these are used in very advanced chronic conditions. Highly Vadashamana, but very Kabavardhana. So it can produce venous-like disorders when you use it in head. So generally, Rasathylam, etc., are not used for head. It's used for Abhyanga of the back side of the neck. So this four thylas actually I use for Shiro Abhyanga and a bit of massage over the back side. Another thing is that this thing can see an inverted baby on their neck. This is what is actually Chinese medicine use this reflexology treatment. It's an excellent method. If you use these massage techniques, you can reduce patients come with muscular spasm, isn't it? Neck stiffness and all those things. You can see the inverted baby here, the ear lobe, and see whether the spine comes, where the spine comes here, this part, isn't it? This is the part where the spine comes. So you can give a massage like this, helix and the helix part. Advise the patient to do this massage. Patient who has got cervical spine, always advise this patient to do this type of massage. And do the massage here. Patient with muscular spasm will get instant relief if you do the massage. And do it yourself. You can use carpacestary or kapuradi. You can do this massage like this, and the spasm will get relief. Instantaneous relief you can see. So that type of massages can be well practiced. And you can advise the patient also to do regular massage over this area. Between the helix and the antihelix. Between the helix and the you do the massage here. Right. That will give excellent results for cervical pain as well as some effect on radiculopathy. Not much effect on radiculopathy, but if you have cervical pain, myositis like that conditions, excellent results. Fibromyalgia also can have good results. In internal medicines, you can use Amrutotram, Pajana Amrutam, like that. Hinkoja is very good, right, for pain. This can be used for patients who have morning stiffness with cervical spine. Right, patient will come like that in the early morning. They have stiff neck, like that condition. You can use Hinkoja as an anubana with Amrutotram or with the Pajana Amrutam, either way. Right. And there is Rasnerandadi and Purnavadi. These two things can be well used. Rasnerandadi, Purnavadi, and Rasta Dashmura. These things can be used for facet joint arthropathy. Rasnerandadi, Charirasana. Rasnerandadi, Purnavadi Kashayam, and Rasta Dashmura. Sorry, Rasta Dashmura Kashayam. This thing is very good effect on facet joint arthropathy. You can use it in various degrees. Right. If you have Pitta and Bandha, you can use Rasnerandadi. Abhan Bandha, you can use Purnavadi or Rasta Dashmura. Then with the radiculopathies, you can use Prasaranyadi and Ashtavaranga. Maharasnadi can be also used. Rasta Saptakam actually it comes in this group, but it can be used either ways. Vada Kapashamana and as well as in that is basically based on the empty of the patient, of the physician. Right. Rasta Saptakam. Judiciously, it can be used for radiculopathy and as well as for basic journals. Okay, so Trayadasham, this can be used in osteoporotic conditions. Sprudhisagaras, that is one of use it very commonly. Can be used in radiculopathies as well as in myelopathies, cervical myelopathy conditions that can be very judicially used. Sprudhisagaras. Actually, myelopathies you should be using media type of treatment. So Sprudhisagaras is very good. Cervical and Mahaprasar may again radiculopathy can be relations. So also can be used for radiculopathy along with the suitable measures. This is the basic line I used to use in treatment. You can ask any doubts so that I can give a further clarifications. Management of cervical ribs, there is no such management of cervical rib. Okay. If that one is producing severe compression, okay, you have heard about thoracic outlet syndrome, radiculopathy. You can do some Sneha Sveda, etc. Actually, Snehapana with Dhanvantaram or Bibliotha followed by Sveda may give some relief. But as far as cervical rib producing compression and severe radiculopathy conditions, okay, so what should be done in patients with sudden muscle spasm in cervical region? One of the techniques I told is that this thing. Then trigger release is one of the beautiful ways. But on an online session like that, I cannot explain how trigger releases can be used. Okay, it would have been an offline class, then can be wonderfully done. Okay, muscle spasms can be very beautifully managed with the trigger releases. So anyone of you practice trigger releases? Any one of you? No, nobody uses trigger. Trigger release can be wonderfully used. Okay. Such type of things cannot be explained on an online class like this. If it would have been offline class, I would have certainly demonstrated how that can be used. Usually, trigger releases can be done over this part. Scalenus, anterior, medius, and posterior are the three major scalenus muscles that are actually producing severe muscular spasm of the neck. So that triggers can be very easily released using manual techniques. Magnesium is also there. But still, scalenus group and the sternocleidomastoid muscle, these two group are the main culprits regarding neck stiffness. So that can be very easily related. Then you can use the various other kiwis, Ologalatha kiwis, etc. can be used. Okay. Very judiciously that can be used. The management guidelines, that is what I just tried to explain. The different Nasya Prayogas. Nasya, Pradimarsha Nasya can be very well encouraged. Okay, Shirabala 7. Very well. Because most of my patients with radiculopathy, I give Shirabala. Shirabala is by far the best choice. There are certain teachers who tell that Gandadailam can be used for radiculopathies, but I have done that in many patients, but not much of a result can be seen on that. Initially, you can use Dandandram also, Avrati. Shiravala is by far the best choice. If you are doing it for Prativarsha, just at this 7, Shiravala 7 Avrtis. Or if you are doing that Marshanasya, then 101 can be used. That can be also given internally also. Shiravala, you can get it in capsule, so that can be given internally also. Treatment for congenital cervical vertebrae fusion. Why should we treat a fusion? Okay, what happens is congenital abnormality is what is that is that it's congenital deformity, right? So it will be there by birth. So all the intermittent foramina, all the nerve roots, etc., will be accordingly arranged, right? That in that particular patient, if they have fused vertebrae, then his intermittent foramina will be so arranged that his nerve will be going on as normal as any other patients, right? So any other changes that are occurring due to stenosis, etc., should be treated as normal cervical spine management. There is no need to treat a congenital fused vertebrae. You find that thing, you understand that there is a fused vertebrae or a blocked vertebrae. You assess that whether this patient have associated lung problems or associated kidney problems, then try to manage that, not the fused vertebrae. Okay, that will be there. You cannot manage that. You can symptomatically manage whatever symptoms he produces. It's most likely that if stenosis occur in that part, our conventional managements may not give the desired results. So Maharaja Prasaran is it's available in capsules. Okay, so that can be used in radiculopathies. Right, radiculopathies of pure. If the patient complains of numbness, weakness, that means myotomal or dermatomal origins. You know the myotoma and dermatomas. Okay, so there are C5, C6, C7. These are the normal nerves, and C5 is actually related with abduction of shoulder joint. If the patient is having problem with abduction or the frozen shoulder thing, there's weakness in abducting. Patient will complain there is no pain as such, but there is a problem in lifting this arm like this. Patient will be having weakness like this. That means C5 is involved. That means flexion is involved. That means C6. Extension, weakness in extension. That is C7 involved. So all these things are directly indicating that there is an upper not an upper motor neuron, lower motor neuron, myotomal neuron. That is a motor component of the cervical nerve is involved. Right. In such conditions, long-term use of Maharaja Prasarani along with other managements, Prasarani Adi or Ashtavarga Dasha, give good results. Right, Nasyam can be used. Snehapanam, wonderful, Tanandram, wonderfully used. Okay, that can be given along with the muscle exercising or muscle strengthening exercises. All other aspects can be used. And Maharaja Prasarani is a very good medicine for radiculopathies and motor nerve exercise. Right, all these are available in capsules. So you can give that. A little bit costly, but still. Late neck folding in babies. That should be assessed very carefully. Why? What is that? What is happening there? Okay, but there is one called as Shashtika Thailam. Can be used as for rubbing up. If there is any neurological involvement in such babies, then you can give this one. So Arasadharishta, gold. That can be small babies, you can give 1 drop. That will definitely help. Right. Dose of lordosis can be due to muscular spasm. Once the muscular spasm is relieved by other aspects, other management techniques, and also loss of lordosis will be corrected by itself. Right.
Sorry to interrupt you, sir. May I read the questions for you? Sir, one question. Can we use Rasana Sapta Kashaya in facial joint arthropathy?
Of course you can use. Of course.
Okay,
Rasana Sapta can be used in facial, but I generally feel that the other one, Pranavadi and the Raskar, Bajari Rasana. Okay, Rasana Sapta can be used or like Amabajra, isn't it? Okay, so I generally feel that Rasana Sapta can be used in arthropathy. There is no of this thing, but I generally feel that Pulanavadi and Rasaranda are more good choice than Rasana.
Okay, thank you, sir. Next question. So, what should be the management of giddiness due to cervical pathology?
Giddiness due to cervical. See, all such things does not need different medicines, right? Giddiness may be due to different causes, right? Should be actually assessing what is the cause of the giddiness there. There is vertebral artery stenosis. There will be blackouts, right? People will be standing like this, and suddenly there will be a blackout, and patient will drop out sign will be there. Right. In such conditions, I generally use Guluchadi. Guluchadi and Kaishar is used for long-term treatment is needed. Other giddiness like symptoms will generally subside with general treatment like this thing. Okay, general treatment for cervical facial joint arthropathies or cervical disc problems. That will be generally subside with all other things. There is no specific medicine as such for giddiness itself. Clear?
Okay, clear, sir.
The
Sir,
thing is that giddiness usually you should be differentiate whether it has got a neurological thing like that. Right. There is a neurological involvement. You can use Saraswata Aristam gold. That is comes in small bottles, drops. So if it's an adult one, you can use 6 to 8 drops. That with the Belaristam or something like that. That will be good results.
okay. Thank you, sir. Sir, moving on to next question. Sir, what could be the conditions where the cervical collar must be used?
Cervical collars.
Yes, sir.
Is that a question?
Sorry, sir.
I didn't get the question correct.
Sir, indications of using cervical collar.
Cervical collars. Cervical collars generally is used when there is severe muscle spasm. Usually in facet joint arthropathies, you do not use cervical collars. Right. That will lead to more stiffness. If there is irritation of the nerve root, like if you just move the gateway reversal, let us give like this, or you give extension like this, and there is severe radiculopathy going on like this. And if you want to prevent that irritation of the nerve root, then only cervical collars are advised. Otherwise, then only cervical collars, long-term use of cervical collars is found to aggravate symptoms like facet joint arthropathies. Right. There is a radiculopathy, irritating radiculopathy. That means the patient is having severe radiculopathy to the particular limb. Then only I advise cervical collars. Otherwise, there is no need for cervical collars. That is also soft collars, not the hard one. Right. Then another condition is atlantoaxial instability. I skipped through that X-ray because of time limitations. There is a instability in the atlantoaxial joint that that can produce severe problems, but that is not managed by us. That should be very. It's a very dangerous condition. So hard collars are used in that conditions. Otherwise, the right collars can be only used in severe radiculopathy conditions. There's no need for the right collars. Right.
Okay, sir. Thank you.
Can
Sir,
be
next.
used for action.
Sir.
Actions can be used judiciously. Right. Actions should be used very judiciously. It's not like you can use fractions like in the lumbar region, etc. But any manipulative techniques that are used in the cervical region should be used with very judiciously used. Because there are a lot of structures there in the cervical region. Lumbar region, you have just nerve roots, or no board or like that. It's very mobile region also. It's liable to injuries also, cervical region. So manipulative techniques should be used very, very carefully. The minimum traction should be used. Just don't use that without a correct idea of the anatomy and the clinical conditions also. It should be used by an experienced hand. Don't allow, if you are running a private clinic or if you have IP procedures, don't allow your therapists to do tractions. Traction should be always done by the medical officer itself. Please see, there is no danger that is produced by the manipulative techniques. Traction should be very, 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 very careful.
Okay. Sir, next question. Sir, can a hypertrophied C7 transverse process result in thoracic outlet syndrome?
It can. Yes. It can. It's compressing the brachial cord, brachial plexus. You can see the brachial plexus is coming from these areas, isn't it? So the transverse process definitely can compress the brachial. Can produce thoracic outlet syndromes. Thoracic outlet is very difficult to manage. It is it's a different compression is there. So can produce.
Okay, sir. Sir, what should be the effect of Uttarabhaktika Grita in cervical pathologies?
I didn't get the question correctly.
Sir, what will be the role of Uttarabhaktika Grita Pana in cervical diseases?
Uttarabhaktika, I generally use that. It is told that it is Uttarabhaktika should be used, but I haven't used that. Okay. General Stabana is giving me a good result. Pravaktika should be like 70 doses, isn't it? I generally don't know about that. Don't know means practical aspects I don't know. Actually, it is told in Navama, isn't it?
Yes, sir. Sir, next question. Can we see any changes in X-ray after giving Ayurvedic treatment in cervical OA?
No. There will be no changes. Right. I haven't seen anyone. But generally, we'll be giving a symptomatic information. Okay, with the X-ray, post X-ray, I have done that. Expecting that there will be a change, but there is zero change. Right. But you can give good results. The thing is that as I don't know, Muhammad Amin was the person who was that question?
Sir, whether
Minu Rose Matas. That question. See,
yes,
see,
sir, Minu Rosana.
see, doctor. The main thing is that one should be trying to give relief to the patient. Okay, that the question you asked was more or less academic. Academics go out of the window once you start practicing. Right. You can have that academic know-how, but generally, these things does not have. I have seen some claims saying that there is rehydration of these spaces, but not generally. I don't see any change. I haven't seen anything like that. Definitely, the X-ray will remain the same. Patient will get good relief. That is mainly because when are you practicing, doctor?
Yes. Just now not practicing, sir. Just now I am studying. I am a student.
Okay, that's why the practice is done. Right. Huh? That's not your fault. When you start practicing, you'll see that such questions does not arise. The pain produced by the patient is not always from this X-ray like this. Okay, I heard about false MRIs. I don't know.
Yes.
There will be patients who will be there are patients with practically no symptoms. But when you take an X-ray, you will have severe MRI changes. Such things can happen, right?
Okay,
So
sir.
actually X-ray changes or MRI changes, I haven't seen that, but I have given good relief to patients, relief and long-lasting relief to patients with the medicines I already do. It's not no any secret medicines like that. You just give this and give some pathya, give some lifestyle modifications, cervical radiculopathy and the cervical OAs, basic joint arthropathies, these interventions. If you get the patient around 40s, not the patient who is in the 60s, usually the patient in the 40s who haven't developed the cervical myelopathy. I haven't talked about that. Cervical myelopathy or any other serious diseases, simple lifestyle modification with these medicines and the Shiro being I told you. Right. And if your patient is having any neurological complaints, go for media drugs. Right. You can simply give them vaja, etc. That can be done. But you can have Risagar Rasa is a good choice. Right. That can be given and that will give you good results. Okay. And also Saraswata Arishta. Gold. Not the normal one. That small one. Gold. Aushadhi Daspuris. Good results.
Sir, please repeat that Rasa medicine and how it should be administered. Sir, please repeat that Rasa medicine. I think Smriti Sagra.
Sure.
Sir, you just mentioned one Rasa drug, right?
Smriti Sagra Rasa.
Sir, please, how it should be administered?
It comes in tablets. You can give one PD like that. Dabar.
Okay, sir. Thank you.
So,
Sir.
Megagalil rasa also Dabar rasa.
Okay, sir.
Okay.
Sir, moving on to the next
I think
question.
that it can be administered up to 21 days with good pathya. Okay.
Sir. What should be the pathyas followed at that time?
Should be the pathyas followed for?
Smriti Sagar and Gangavira.
The pathya's followed for Smriti Sagar rasa.
Yes, sir.
I am getting a break sound.
Sir, yes, sir. What should be the pathya followed for Smriti Sagar rasa?
Smriti Sagar rasa generally you do not need a Vachare pathya, but generally you can avoid spices like that. Non-vegetarian should be definitely avoided. Like pickles or such things should be avoided. That is enough. Not much, not a stringent diet should be followed for Smriti Sagar rasa. The thing is that if you use a restaurant, this is for 14 days. At the maximum, you can go for 21 days. Right. Then that is enough. That will give you the desired results. If not, you take a break for 1 month, go for other herbal medicine, return to the drug. Okay, that will not produce much of a. Ekanga is also 14 days normal vegetarian diet plus avoiding of spicy foods. That's enough. Right.
Thank you. Sir, moving on to next question. Whether carpal tunnel syndrome can show any symptoms in neck region?
Carpal tunnel syndrome and neck pain should be differentiated. That is the thing. Right. It can produce radical. It is told in the text that carpal tunnel can produce reverse radiculopathy extending up to the neck. That is there. There is one simple test that can be done, a Fallon's test. Okay, carpal tunnel syndrome, you put this like this. Right. Action of both like this Fallon's test. Keep it this for say 1 minute or so and see whether numbness is increasing on both sides, especially in the hand. That is it. It is carpal tunnel syndrome. It can rarely produce symptoms extending up. Generally, carpal tunnel syndrome radiculopathy does not extend above the elbow. Generally, it does not. But occasionally, it can go up also. Our text, which is called as Vishwaj.
Okay, sir. Next question is from Dr. Megha. Sir, is in treatments like Piju and Podikiri useful in cervical conditions?
Very good. Podikiri can be done. Podikiri, actually, Podikiri should be done in Aviki. You know that Aviki. Okay. So that can be herbal water can be made using Puliyala, tamarind leaf, and what is Vadangalli. Megha Malayaliano.
Hello, sir.
Ano?
Yes, Malayali, sir.
Vadangalli leaf. Okay. That can be put in the Avi steam can be used to that can
നാഡീസേദം പോലെയാണോ സർ ഉദ്ദേശിച്ചത്?
എന്താ?
നാഡീസേദം പോലെയാണോ സർ ഉദ്ദേശിച്ചത്?
നാഡീസേദം പോലെ തന്നെ.
Okay.
That can be done. Or dry podikiri using kola. That means when you take the kora cloth, don't put it into 2 layers. Put it in a single one. Single layer kora cloth should be taken. And the kiri should be loosely tied. Right.
Okay.
So that when you put the kiri, the soda will be coming through this cloth. Okay, and just don't do severe massage like this. Just apply the heat like that. That will give good results. Right.
Okay, sir. Thank you.
Kolalotadi is best. Kolalotadi, simple cases, Kolalotadi will give good results. That doesn't go for Kotajukadi. Kotajukadi sometimes in Pittaprayodi it can produce rashes and things like that.
Okay, sir. Thank you, sir.
സർ ഒരു ഡൗട്ട് കൂടി ഉണ്ട്. സെർവിക്കൽ കണ്ടീഷൻസിൽ നമ്മൾ നീജോനൊക്കെ അപ്ലൈ ചെയ്യുന്ന പോലെ ജഡാമയാദി ലേപം അല്ലെങ്കിൽ നാഗരാദി ആ ലേപത്തിന് അവിടെ ഇമ്പോർട്ടൻസ് ഉണ്ടോ?
ദൈവത്തിന്റെ പറഞ്ഞില്ലേ അത് see that the dosha should be looked dosha is predominant, right? The patient is presenting with pain and sickness. Pain is always related. Simple techniques can be used. Not complicated things should be thought of, right? Complications when you may try to think complicated cases, treatment will become very difficult, right? Think of three things. We have seen in Sushruta also. There's yoga. Adadrde nasti rujana bhaga tadrda nasti. That slogan is there, isn't it? Without Vada there is no pain. Without Pitta there is no bhaga. Without Kama there is no stiffness. Right? Have you heard that slogan?
Yes, sir.
So that should be applied. Right. If the patient is presenting with pain and stiffness, then one should be thinking of a Vada Kapha predominant condition. Only thing is to understand is that whether Vada is predominating or stiffness is predominating, Kapha is predominating. Pain is more than stiffness. That means Vada is predominating, Kapha is less, and vice versa. Right. And you should be selecting drugs accordingly. Okay. If a patient is presenting with the Pitta predominance, you can just feel the warmth of the patient. Cervical condition also, and other parts also. Just put your dorsal part of the arm and whether see how warmth of the particular region and see whether there is a Pitta predominance also. Right. So if you have Golavatadi, Gradumadi, and Patajukadi, that can be used in Vada Kapha conditions. If Kapha is predominating, you can go for Patajukadi. Right.
Okay.
The other things, Ulamishadi and Jadamayadi, etc., should be used in abdominals. Then some persons use Dhanyamlam. Dhanyamlam is also used as for making puja. That should be used in Pitta predominant condition. Dhanyamlam is generally Shridagirya. Right. So in painful conditions, try to avoid Dhanyamlam by using nevas. Right. Simple things that can be practiced. And cervical pain, again,